your space. And Joelle for joining me. Her story is quite helpful here. She and I are both passionate about this topic because it's a professional curiosity for me, and it's something that affects all of our lives, and it's way more complicated than we usually understand pain on the human level. And if we can just learn from other people's experiences, we can kind of understand our own experience with pain a little better. So we're going to go through kind of how pain works on a biological level, but then also anomalies that we see and how it behaves sometimes, including Joelle's own story. So first thing here is like just basic definition of pain. It's one of those things like you experience it, but you never think about like, okay, how would I write it out? So like the dictionary definition of physical suffering and discomfort caused by illness and injury. Okay, sounds like very in the tissue, right? But the medical definition that's like, this is the more current one that is, it's taken a while for the definition of pain to really evolve. Unpleasant sensory and emotional experience associated with actual or potential tissue damage or described in terms of such. So the new medical definition really leaves a lot of space for like the human experience of it versus it being an objective phenomenon that's very set. And our experiences can vary really wildly for some mechanisms that we'll get into here. So like everybody has had many experiences with pain in their life, and we probably all had some kind of crisis in your life with significant pain, and we'll have different words for what the pain feels like and how we experience that pain. I want to dig into kind of some of the nuances of why pain feels the way it feels and why we experience what we experience. We all probably also had an experience where our concerns weren't really met with a lot of understanding by the healthcare system, where we felt like maybe unheard, or we felt misunderstood, or we didn't get a good answer for what we're going through and a good, clear understanding of what to expect. And this is a strong subject for me because I feel like through my career as a PT, I've seen there's been a very big evolution in how we work with people in pain and what we think it is. And I've seen a lot of my own mistakes over the years in how I interact with the patients, and it's really evolved over time. And I want to kind of put that forth for other people's benefit. Okay, so there's some models that the medical world has used for pain over the years. The biomedical model has like been the historical one, which is really just looking at tissue. Where does it hurt? We're very good at diagnosing like, is the tissue torn? Is it inflamed? What's occurring right in that area? Assessing the level of tissue damage, and pain is usually just kind of inferred based on how damaged it is. So if there's a bunch of inflammation in the tissue, we expect that to hurt. If it's torn, we expect that to hurt, but it's just sort of an assumption. It's not really always perfectly in line with people's experience. And the new model of pain that is really coming out there's multiple fields of science that are kind of converging on this right now. Looks at the biology, so like we do look at like what is the health of the tissue, but also the psychological state and the social cultural influences. So it's called the biopsychosocial model. And we exist in a very specific culture in Bend around sport and outdoor, lifestyle where, as Americans, we're very individualistic and we identify ourselves as like, I am a mountain biker, I am a skier, I am a runner. And we put that it's a very core nugget to yourself. And it has an effect on how we interact with our own pain. And people in other cultures have different words they use, and they have different, it affects them in a different way. And I might talk about that at some point here, because I have some experience with the Sonoran Mexican culture, and then working with natives up in Alaska. They use different wording when they talk about their own pain, and it's a little bit hard to explain quickly. I'll maybe get to that later. So in the Western model of pain, we have classifications of pain. So nociceptive pain is like you smash your finger with a hammer, right? It hurts like hell. You can't ignore it, it's not in your head, that is clearly like, you stub your toe, bright flash of sensation, that's nociceptive pain. And when we say anything with noci at the beginning, noxious, the word like just a noxious impulse is what that means. And then neuropathic pain is like, there's degeneration or injury in nerve, and it's making the nerve kind of buzz, and so there's just feedback coming out of the nerves, and so you feel that. Like, if you have neuropathy, you'll feel kind of a buzzy sensation in nerves, and but it may fluctuate too. Like, you might not always feel it, sometimes you do, sometimes you don't. But the explanation is that the problem is in the nerve, and it's sending a signal, which you would assume is damage, but damage and pain are not perfectly aligned. Radicular pain is like, you injure your back and you feel it in your foot. You injure your shoulder and you feel it down lower, like it's radiating away from the actual focal point of it. And those top three, nociceptive, neuropathic, radicular, they're fairly like common words that you'll hear if you go to see the orthopedist or neurologist. But the last one is the one that Joelle and I wanted to talk about. Nociplastic pain is one that most people don't hear that word, and we don't understand how it plays into all of our injuries, because it's usually only talked in terms of like, oh, you have phantom limb pain, that's a type of nociplastic pain, which is like different from all of our pains. But my point is that a lot of us experience subtle bits of nociplastic pain in our pain experience a lot of the time, and it's confusing. And there's a very specific way you want to interact with that pain to promote health. And there's ways we don't want to interact with nociplastic pain that Joelle can expand upon. It's a really confusing pain because it's hard to understand how you can have tons of pain in your hand or your foot, but it's not damaged. The pain is real, but what is it? Like, why do I have this pain? Why is it still lingering? How do I make it go away? It's incredibly frustrating when you have that type of symptom. I deal with it all the time with patients, but rarely do people have unless you go through an experience like what Joelle went through, it will feel foreign, it won't feel real. So we'll kind of dig into how nociplastic pain works. Just as a general, how does pain work? You got a diagram here, okay, so you bump your knee, there's the red signal is there's a signal coming out of your knee that nociceptors fire off. They go to your spinal cord, they track up, and there's junction points in the spinal cord, and there's junction points in the brain, and then the somatosensory cortex, the outer part of your brain, is where mostly where we are. Your sense of what's happening, what you're doing exists. But the point is that the signaling goes through a lot of junction points as it goes up your spinal cord and as it goes through your deep primal brain that can either facilitate the signals going through, or it can block it, or it can dampen it down. And you'll notice in this diagram that there's blue lines that are meant to be running down. So pain is not a one-way track. Smash your finger, pain signal goes, brain reads it. There's signaling coming down the other direction as well that can allow it to open up or to block it, essentially. If you are if you're fighting for your life with a bear at that moment, you don't need to deal with every individual injury at that moment. You need to continue fighting with the bear. So your brain will literally, it's not just that you have smothered, you're not just flooded with corticosteroids and adrenaline. It's the task at hand is more important than dealing with the pain. So your body will block those signals coming up so you deal with the threat at hand. And sometimes the way we think of can actually allow those signals up versus block the signals coming up. And some of the things that Joelle's going to talk about are about basically how do you think in a way that limits that signaling coming up. So if you just have pain pouring out of your foot and it's taking over your mind, there's ways of thinking that kind of trim that or allow it up. And we'll get into some of that. Here's another picture. This stuff's way too detailed. You don't need to know all the details of every little track, but the point is that there's a lot of little subtle connections between, so on the left there where it says nociceptor, the little branchy thing, there's a receptor in your muscle or joint or skin or anywhere that when you signal it is a signal of noxious something. Like it can be heat, it can be pressure, it can be cutting, it can be a lot of things. It's not a pain signal, it's a noxious signal. But it goes up to your spinal cord and then it goes into your brain. And an interesting little thought here is like you'll notice one of the things that's flagging through is there's the thalamus, upper right corner. Thalamus is like the junction hub in your brain where like, if you've ever known somebody with, I can't think of the name, what is autism. Like somebody with an autism spectrum issue, like they have a sensory processing problem where like it's just flooding information into their brain. They can't make sense. There's too much coming in. Like the thalamus is an organ in our brain that is essentially like filtering information coming through. Anyway, food for thought. It's all involved in the story we're going to tell. And then the other thing I want you to think about for the nervous system, because when we feel pain, we don't feel pain in your joint or in your muscle or in your tissue. You feel it, your nervous system is where you feel, right? And your nervous system is made up of multiple components. There's the autonomic nervous system. You breathe, your heart rate, your digestion, all these things are subconscious. You don't have to control them. They're happening autonomically. Well, we have two branches of that. There's the sympathetic side, and like if you look at the diagram there's a brain on top, and then it's meant to be a spinal cord running down the side, and there's like a little chain running down the side. So in your spine, there's a chain of tissue running the side of your spine called the sympathetic chain ganglion, and it's where like stress signaling can go out and like turn up your heart rate, tense your muscles, change digestion. Like the things that you would do when you're in a stress state are signaled through the sympathetic nervous system. The parasympathetic nervous system is like what you use to rest and digest and heal and really recover. So you can think of it like there's two polar or competing components in your nervous system that are managing the base state that's not like your conscious thought. And some of the things we think of can turn up sympathetic or turn up parasympathetic. And in a lot of us, like it's very stressful when you're in pain, so it can end up being like a very high sympathetic state. So, would you like to?
Sweet.
Now she is going to tell her story.
As warned it. Cool. So I guess to start, thank you guys all for coming. I'm excited to be on this end of my story. When I was in it, I don't think I thought I'd ever be speaking about it in the past tense. It was pretty consuming. Pain is consuming. You think about it a lot, and when you are in it for a long time, it feels like it will never end. But before I get started, I wanted to reiterate two things. One, if you have a sports injury or you are in pain, my trajectory is not necessarily your trajectory. I don't want anyone to think that this is where they're headed per se, and we're going to talk a lot about how to not go that direction and what you can do to mediate your own symptoms. And then at the same time, while this experience is unique to me, it's not unique to kind of our culture as a whole. Chronic pain, or persistent pain, as I like to call it, it's a little less doom and gloom, is pretty prevalent, especially in the United States, and it was on the rise during the COVID-19 pandemic as people experienced more psychological stress and fear. It is an epidemic of fear, chronic pain is, and so with that, I'll go ahead and get started. So my experience with injury and persistent pain began in January of 2021. It was during a rather stressful time in my life. I had a lot going on. I was working full-time, I was going to school full-time, I was training full-time. I had signed a contract with Arc'teryx for skiing and running, and so I had some lofty goals on the calendar that I was putting a ton of time and energy into. And my initial reaction to my left knee pain was like immediately fear and dread, and it felt like a big threat to my goals, but it also felt like a threat to my livelihood. With everything that was going on, I felt like the one thing that was constant and consistent was my ability to train and get out and run for an hour and a half in the morning. It was a time of quiet, and to think of losing the ability to do that became all-consuming. and it really scared me, especially with the goals I had set for running. And that kind of started to set the stage with what we know about pain being biologically influenced, yes, but also psychologically and socially influenced. The psychological, the dread and the fear started to perpetuate what I was experiencing more than the physical. And I remember at the time joking with my partner that eventually something's gonna snap because I'm just so stressed out and burnt out, and this ended up being it. But as I continued to fear my pain and bounce between physical therapist and physical therapist, it only grew worse. It became more limiting. I lost the ability to run. Eventually, just like going on a hike or a walk was really difficult and uncomfortable. And with all of that, things felt worse. I was more fearful. It was pretty emotionally challenging and heavy. I did what I've always done if I've had this little sports injury. I tried to find other activities that I could do to maintain fitness and kind of stay engaged in the outdoor community and hang out with friends outside. But as I continued to kind of fixate on the knee pain, other stuff started to creep in as well. So there'd be this like new shoulder pain, and now I can't climb because my shoulder's in like 10 out of 10 pain. And with every activity that I lost the ability to do, or at the time perceived I was losing the ability to do, I started to doubt my body and my ability to heal and recover. I think especially I was 24 at the time, so being younger, to have this feeling that my body was failing me so soon felt like a death sentence. It felt like there's got to be something more going on, or something has to be pretty wrong for this to be happening at this age, especially while all my friends are doing all the things and I'm now just hanging out at home. And things just got worse. By November of 2021, I actually did sustain some like mysterious trauma in my right knee and ended up dislodging some scar tissue from a past ACLR. So on top of the mysterious left knee pain and the shoulder pain, I now had like a big swollen right knee, and there was clearly something wrong there. And through all of this, I heard a lot of what we'll talk about later. They're called nocebos, so they're kind of this idea that our language we're using can negatively influence like our progress and our healing. I was told my kneecaps were aligned incorrectly, and I'd have to have my tibias fractured and realigned in order for things to feel better. I heard that my ACL must have retorn, and that's why my right knee is swollen and irritated, even though I have no instability and am negative for all of like the anterior drawer tests. Oh gosh, there are so many. My feet are weak, or they're too flat, or I pronate too much, and all these things that you really can't tangibly change, and there's no solution. They just kind of leave you with, oh great, like I have all of these problems and I'm doomed. Again, it was a pretty heavy time. If you've ever been injured or have done a big race or something and you're not able to train or do what you love even for a week, you kind of start to feel the heaviness of that. And so going on 7-8 months, it was really starting to set in. I was fairly depressed. Just a difficult time. Eventually, a friend of mine referred me to a physical therapist in Portland who was pretty well versed in like this idea of modern pain science. And at the time, I was kind of out of options. I was getting blood work done to see if I had an autoimmune disease. Everything was coming back normal and negative, which is great, except when you're looking for answers. But I was willing to do anything I could to get some semblance of my life back. So I went and saw this specialist in Portland, and he started to ask me questions. And for the first time, a practitioner or a physician asked me questions about my life and what was going on in my life instead of my knees. He didn't even really assess my body or my knees at all. He just asked me how my work life was. He asked me what my relationships looked like, how much stress I was under. He asked what my mental health was like since losing the ability to do all these things that I loved. It felt more like a therapy session, and I think I just kind of like poured out my guts to him. And then he explained to me how pain works. And he started to explain this phenomenon called central sensitization. So essentially, when you've been kind of living in this state of fight or flight for a long time, you're super aware of the sensations in your body, you're hyperfixated on what's going on, your nervous system starts to become sensitized. So central sensitization is increased responsiveness of nociceptive neurons in the CNS to their normal or sub-threshold input, which essentially means things that normally wouldn't raise any flags are like sounding the alarms. And so, for example, at this point, I had widespread joint pain and my hands would hurt, and like clothing on my skin would feel uncomfortable, and I had sensitivity to light and sensitivity to sound, and I couldn't go eat out at a restaurant because it'd give me a headache from listening to people, and I couldn't explain what was going on. And like we talked about, we have all these nociceptors throughout our body. They can gauge temperature, mechanical sensation, stretch. Basically all this information now was coming up, and instead of filtering it out, my nervous system was projecting it and responding with pain, and I was fatigued. But he explained it in a way that made it sound like something you could overcome. It's like you can desensitize this system, it's not permanent. And it was the first time someone kind of provided me with an idea of the big picture and then gave me some direction. So one of the things we talked about was how pain actually, you can think of it as like a dial in your nervous system. Somewhere in your spinal cord or in your brain, there's this like volume dial. And when you've been in pain for a long time, you can also think of it like a mountain. There's a tissue threshold that's up here, but when you've been in pain for a while, your nervous system becomes sensitized. So what your nervous system perceives as dangerous is like way down here, even though your tissue tolerance is probably closer to this line. And there's a lot of ways you can influence this. There's a lot of things you can do biologically, so you can provide changing stimulus to the physical body, but then there's ways you can change the way you think, the way you perceive, and then the kind of interactions you have in your day-to-day. The first step was to address my thoughts, my beliefs, and my perceptions about myself, my environment, and my body. I had to reintroduce activity in a slow and pretty methodical process in a way that like allowed me to actually desensitize these movements and not provoke things more. And then I had to incorporate grounding and mindfulness techniques to begin to communicate safety to my mind and body and get my nervous system to stop firing on all like million cylinders. And then there were 3 power statements which guided this whole process. The one was, it's usually always all things. The next was, my hurts can't hurt me. And the last was, this is the art of living, the only way out is through. And I'll explain those a little bit more. So it's usually always all things. It's kind of a confusing statement, and it was really frustrating for the first couple of months because it made me actually open my mind and think. But Michelle Grimm, the physician I worked with out of Chicago, was the one who would say this in almost every session I had with her. I'd come in and be complaining about like a pain flare, and I can't figure out what I did. And she'd go, okay, well, what else is going on in your life? And it reminded me to consider all of these aspects when experiencing increased discomfort or something going on. So instead of just, okay, did I overdo it or did I exercise more? I started to think of, okay, who did I interact with today? Is it someone who I've had conflict with? Does it stress me out? Was there a thought that just popped into my head that was rather negative? Am I anticipating something? Do I feel uneasy? Am I hydrated? Have I eaten foods today that irritate me? I have a gluten sensitivity. If I eat gluten, I feel worse. So that's an example of the biological, but that's just like one tier of the picture. And then I could use these questions to kind of reduce discomfort. So if it was something going on where I'm having really negative thoughts and I'm getting like little pain twinges, well, I can attend to those negative thoughts and maybe counter them. If it's a conversation I'm avoiding with someone at work because it's uncomfortable, I'll go push myself to have the conversation, and I would see a direct reduction in discomfort because of these things, which was pretty powerful to see. The next statement that kind of guided the process was that my hurts can't hurt me. And this one was pretty big. It was a reminder to reflect upon the poor correlations between pain and tissue damage, which we'll get into a little bit, but there's, especially with orthopedic issues like degenerative joint stuff, there's actually a pretty poor correlation between tissue change and pain. It's more correlated with other influences in the body. And for the most part, tissue changes are correlated with age versus pain experiences. But this statement also reaffirmed trust in my body. It was also a powerful message of safety that kind of immediately just took the threat down. And it also reminded me to recognize that even in the presence of tissue damage, it doesn't have to mean that A, my personhood is any less, or that I have to experience pain. When I had my right knee surgery, they found like a teeny cartilage lesion from where old scar tissue had like compressed my patella, and the medical assistant who did my post-op, which that in and of itself is kind of weird that he did that, told me that every time I went up and down the stairs, if I felt pain, that was where the pain was coming from, which is not true. He also told me I would never be able to do lunges or squats or run ever again in that appointment. Yeah, and none of that's been the case. I was doing lunges within 3 weeks of surgery, and they did not hurt. So another example of nocebo's language that physicians use can be really powerful, or medical assistants. But again, there is tissue change in my knee, and I don't feel that. I have no pain with that. And then the last one is that this is the art of living, and the only way out is through. So this process really forced me to pay attention to everything that had been going on in my life, the ways I was overdoing it, the stress I was experiencing, the relationships I was avoiding, the conflicts I didn't want to engage in. And while it was really uncomfortable to process through all of that and to endure, this act of recovering from persistent pain kind of called me into a new way of being. And it acted as a framework for how I try to walk now in my day-to-day. So I'm much more mindful, much more aware of myself and how I'm feeling, and can attend to kind of my internal state before it turns into something. An example, I still have some like wonky knee pain sometimes. I did not get a lot of sleep last night, and about noon today, 1 o'clock, I was getting really tired, and I was trying to push through, and my knee started to hurt, and I was like, oh, it's because I'm tired. And I went and tried to lay down and take a little nap, and when I woke up, it was completely fine. So sometimes these things now act as just little cues for like, okay, like you're missing something, like go take care of yourself. And 7 months ago, if that had popped up, I'd thought I'd tweaked it or done something, and now it's like, no, I just need to go take a nap. So yeah, that's kind of been the way things have transitioned for me. And it's also inspired me to enter into this field. I'm currently working to get my master's of social work so I can get credentials as a licensed clinical social worker and enter into the chronic pain field. It's kind of a newer field of social work or therapy. There's some really cool studies out there where they're integrating like cognitive behavioral therapy and mindfulness techniques as pain reducing practices, and they're seeing like, 90% of the people in this study are pain-free, and these people have had chronic back pain for 40 years or something. So it's pretty incredible stuff when you start to incorporate the psychological and the social cultural influences with the biological. You find how resilient human bodies and minds are, which is super exciting. And then we have a little graphic.
Joelle made a hilarious little cartoon of the story of Gerald.
Yeah. So a little visual for us all.
Just a quick little cartoon of two paths that, like, somebody with a, say, Gerald fell and tore a couple ligaments in his ankle, right? In the good scenario, he uses his recovery and downtime to attend to his internal state. He eases into cross-training and finds he really enjoys cycling. Gerald spends time with his family and friends while recovering. His employer is understanding and lets him have time off work to heal. Gerald's health team assures him that his body is capable and will heal. Gerald catches up on sleep and allows himself time in a self-care routine, right? Like all like self-care acts, right? Well, feels great. Good job, Gerald. So like, we wanted to like paint a picture of like, okay, how could it go wrong? So same exact injury.
This is what I did.
Let's say is a grade 2 tear of his lateral ankle. Right away, like fear's really high, anger's high, hopelessness is high. Like, this may have been really consequential to this character in that, like, he had goals set up, now he can't run the race he wanted to do, he can't be the athlete he wanted to be, and there's this, like, spiraling doom that can show up in, especially in our culture around here, when you have an injury that can get in the way of your livelihood, it can get in the way of your sense of self. And we tend to kind of bottle that up as, something that I just got to deal with this and I'll get through it, and once it's healed I won't have to deal with this anymore, is kind of the train of thought. But in reality, if you hold those things in, it does have an effect on your physical healing. And some of us can end up with spiraling thoughts around these scenarios. So we came up with some with him, I never see my friends, this injury is taking forever to heal, my body is bad, this ankle's ruined forever. And literally half the people I see recovering from surgery end up with a little bit of this train of thought. It's really easy to perseverate on the possible negatives that can come out of the scenario and just play out the what ifs in your head. And it can be really triggering. When we're doing that, this state that Gerald's in right now, going back to that idea of sympathetic and parasympathetic nervous system, you're driving up a stress state inside the body, which is not a healing state, and it's a state where we create hypersensitivity to pain. So just sitting there ruminating on all the negatives that can happen can end up being something that starts affecting your physical pain. You go back to your surgeon and they're like, oh, his healing's doing great, but he's in turmoil. This patient is having lingering pain, he's not sleeping well, he's hurting all the time. This can happen where it's more about how well is this patient resting, how at ease are they, how well are they buying into the process of healing versus sort of being in turmoil constantly. And we don't get validated for that a lot when we go and we voice this to our healthcare professionals. A lot of times you get nocebos like what Joelle was getting, you need to try harder, you gotta strengthen your ankle, or you gotta, there's some assumption that you didn't do something right, essentially, is the reason why it's lingering around, versus just you being stuck in a state of, chronic, anxiety and sympathetic state. But like Joelle, if you can take the time to be creative in this and start to learn about all the details, you can change even a situation as bad as this little cartoon guy we made. Well, long story short, he does great. Good job, Joe. So we had come up with this idea that pain is funny. When you've had pain that's been around for a while, if you had a surgery and it's been there for 4, 5, 6 months, and you've got symptoms that are really, really irritating you, you can get into a paradox situation where we put our attention on, I need to fix this pain. I need to put effort into fixing this pain now. And there's, you start at the top right bit. You put all this attention on fixing the pain. When we focus our attention on pain, it creates hyper-awareness of that area. It almost sets you up to have increasing sensitivity in the area. And if you're in a really vigilant state, you're I want to fix this, and I'm going to put all my effort into fixing this, you're actually kind of engineering how to amplify the symptom in the area. But it feels, from the standpoint of an athlete, if I try hard, I can get through this quicker, but you're inadvertently kind of spiraling here. And a lot of people end up kind of getting into a state of hopelessness and despair, where you get into this state of urgency where you're okay, now I'm getting behind, my training's getting behind, I'm losing strength, I gotta try harder. And trying harder is not the way to get through pain. It's much more about trying smarter and seeing all the facets of your life that affect pain. And this even applies to very orthopedic things. You could be recovering from an ACL reconstruction and get caught in this loop. It's probably something I see in half the people I see recovering from surgery. Let's go to the idea of a placebo, right? Everybody knows what the idea of a placebo is, right? It's this idea that if somebody gives you a pill and says this is medicine, it's going to help you, it helps you even if it's nothing, right? The idea of something can spark physical change in the human body. If I give you something that tells you this is going to make your pain less, or this is going to make you feel stronger, that thought manifests through your body, and it becomes reality on some level. It's not it's always validated in research, like, oh, we test this new drug against a placebo, like the placebo isn't real, and if it's better than placebo, the drug is valuable, right? But placebos themselves are very real, and they're something that we experience all the time in our interactions. And like, there's factors that we can study on what makes a good placebo. So like empathy from your clinician and the perceived expertise. So like, Joelle seeing an orthopedic surgeon who's telling her that she needs to manage these parts of her life is a good example of like, okay, this person knows bones and they're telling her, your bones are good, you need to manage this a different way, is a perfect scenario, because if it was like a psychologist, you'd be like, yeah, of course you're going to tell me that, like, you're not a bone doctor, right? And then I'm a physical therapist, an orthopedic specialist, and I can say like, you have good bones, we need to work on this on a different level. And if you buy into that, it actually sets in motion positive change. Now, also invasiveness of the treatment matters, like sham surgeries actually make people feel better, which is, we could talk about that for two years. Nocebos are also really a common thing. So I put up some like common quotes that I'll hear from people that they hear from, you go in, you get an MRI of your back, it hurts really bad, doc says, your disc looks like a burnt cookie. And they're like, oh, Jesus. Like, that ain't changing. Like, there's no room for hope in that statement. And when somebody comes in and they're like, my knee hurts, let's take an x-ray of it. Oh, it's bone on bone right here. And they're like, oh my God, that sounds horrifying. Like, it must just be grinding it off and like sanding itself down. And like, that's pretty demoralizing. And it really like provokes a fear response out of the body that can set in motion all kinds of issues. Now, like, I'm not saying...
speak to that really quick. The day I saw the MA, and I'd had those 5, 6, 7 days post-op, and like my knee hurt because it'd just been chopped open, but like I didn't have pain with stairs. And then this guy is like, oh, you're gonna have pain with stairs because of that like lesion this big on your kneecap that only touches in this teeny range of motion. And for 3 days I had pain with stairs. And then it went away when I was like, this is literally because he told me I would have pain with stairs. Which is the suggestibility of the mind. It shows how powerful it is.
Can I ask a question? In those 3 days so you heard that information from your clinician.
Yeah.
What was your, like the click that made you say like, bleh?
I think I was far enough into kind of this understanding that even if there was tissue change or damage, it didn't need to mean pain. I was enough into kind of starting to believe that, and then I was like, okay, I've had 7 days where I did not have pain with stairs, I haven't done anything different, but I did get really upset, and I knew that had a connection. And when I kind of like, I think I sat down and like wrote it out and like was like, no, like you were just feeling this because this idiot like told you that stairs are gonna hurt, and it was within like hours and it was fine. And then it was like, oh my God, that was just my brain. And I kind of I'd like mentally take check of these or like write them down, and I'd build evidence of these things so that in the future, if this popped up, I could look back and be like, okay, like that one time, it totally was just like your thoughts. But it definitely, I battled with it for a couple days. I was pretty upset. Yeah.
Mm-hmm. And I don't want to invalidate, like, orthopedic surgeons are great, and there are all kinds of problems that require orthopedic surgery. Like, you can have a severely degenerated joint that, like, happy thoughts will not make move better.
Yeah.
But that being said, I want to make a point of, I got obsessed with doing ultra running in this last 10 years, and the people I'm impressed with are the like 70-year-old people out there running 100 miles. And like, you look at all of their x-rays, they look like this one on the right. So like, here's 2 x-rays of somebody's knee. Now this is 2 different people. You would look at that one on the right and see the loss of joint space, like the one on the left with the blue, there's lots of space there where we'd expect cartilage to be, and the one on the right, it's collapsed. Now if you went in and you're like, my knee hurts, they'd look at that and say like, well, you have bone on bone here, it's grade 3 osteoarthritis. Can do an injection, which will be an anti-inflammatory, we can do a joint replacement. It's very much like, you have pain because your bone is worn out. But the point, most of us would, if you have a knee like that, this knee on the right doesn't necessarily hurt, is my point.
Yeah.
that knee may move fine and may have no pain associated with it whatsoever. So sometimes like the words that you hear of, oh, I'm bone on bone, like now you're going to start to limit yourself and you're going to start to avoid loading it and moving it because you fear that joint. That can set in motion a real decline in somebody's behavior. And then, so this is a table I pulled out of a really interesting meta-analysis of, there's like thousands of people that were asymptomatic of different age groups. So like you look at the top 20 through 80, these are all things that we find in spinal MRIs, like disc degeneration, disc height loss, disc bulging, facet degeneration, spinal listhesis. And the striking part of this is like, look at age 20. At age 20, essentially 40% of people are showing disc degeneration at age 20. So if you go in there and you say, by the way, and these are all painless people. So to be in this study, no symptoms, active people, feel fine. If 40% of people at 20 have disc degeneration, then that's not a good explanation for why a person that's 20 years old has pain. It's an incidental finding, essentially. It's a sign that they're aging at that area. Now, if you have, like, say these are your two knees, and one looks like the one on the right and one looks like the one on the left, and like, well, clearly one is degenerating differently than the other. Something needs to be done there. But usually, they look fairly similar, is the point. And there's actually been quite a few studies that show that people that see their MRI findings do worse because you point out like, Jesus, I've got disc degeneration, I've spinal listhesis, facet degeneration, like, give up. And it sets in motion people not trusting themselves. And healthcare practitioners know this, so they're generally fairly strategic about like, okay, like, don't worry about this. Because it doesn't point out like, oh, you look really good here, this is great. It just only points out things that are wrong with you or seem wrong. So we wanted to get into some ideas of like how weird pain can be. Now, I brought a mirror and I want people to play with this at the end. Something that we do with phantom limb pain and with like significant pain. Actually, Joelle played with this on her foot.
Oh yeah, I forgot about my foot.
If you sit with a mirror like this, it will look like, okay, I'm looking down and it genuinely looks like I'm seeing my right leg and my left leg and my right hand and my left hand. But it's clearly just a reflection. But your brain gets visual confirmation. Okay, I'm going to open both my hands. Okay, I see that open. Close both hands, open both hands. And you get this, okay, like that is my hand, because you can confirm it with the feedback of moving your fingers and then the intention. Now you start doing something different. Okay, I'm going to only open my left hand. Ooh, weird, okay. I'm going to move maybe just my middle finger on both sides. Okay, I'm going to move it just on my left side. And then you see it, it's like it doesn't make sense for a second. It's not vibing, or it's not syncing with the visual feedback. Now, in treatment, like this is an image of somebody, it's their left hand is what you're looking at with the little red light on it, and the hand on the right is a real hand, the hand on the left is a plastic hand, and so they'll sit there and they'll touch both hands, and the person's like, oh yeah, looks like you're touching my hand, looks like you're touching my hand. And then they start mixing it up, like I'm going to touch both middle fingers, and they touch an opposite finger. Okay, looks like you're touching my middle finger, but I feel my ring finger being touched. And in this one, they were actually putting like a hot spot on it. So that little red laser is like kind of cooking the finger a little bit. And so like, okay, I see you touching my middle finger and it kind of hurts. And now I see you touching my middle finger and it hurts on a different finger. And it doesn't match. And these little fun games can kind of create confusion in the system. And I found a video I want to play here of phantom limb pain. Because phantom limb pain, how do we turn up the volume? Extreme example of how weird pain is. And I want people to think of it as not different pain, but just an example of how odd pain can be. Because
it's a pain people with amputations may feel in an invisible limb, but Dr. David Burbrayer, a physiatrist at Sunnybrook, explains phantom pain is very much real.
The phantom pain is coming from the brain. It's a perceived impression, what we call an engram. The brain has a picture of your residual limb that's absent.
Bruce Tompkins lost his leg when an infection settled into his bones and he developed an advanced stage of localized osteoporosis.
I was actually walking on 6 broken bones when it was finally diagnosed, and I only had really 2 choices: to live with the amount of pain that I was living in and not walk normal, or lose the limb and start a new life with a prosthetic, and I chose the latter, of course. There was a month at least where I went through a mental crisis saying, how can a leg that I don't even have cause this kind of pain, you know? The phantom pain that I get daily, which I still get, is just kind of a tingling and a numbing. It just allows you to realize that feels like your limb is still there. But the severe phantom pain, I can only describe it as your foot being in a bucket of water with piranhas in it, or hot coals. It gets so debilitating that I've actually huddled into a corner and just cried myself to sleep because it just won't go away.
So how can you treat pain in a limb that doesn't exist? Experts say with a mirror and an open mind.
Mirror therapy is using a mirror between the limbs in order to allow the brain to think that the intact limb is the absent limb, and then allow a professional to treat the intact limb as if it were the absent limb.
And go.
If, for example, the toes are curled up and on the absent limb, as the patient perceives it, if they could move the toes on the intact limb and move it up and down, the brain will tell the individual that the toes on the amputated limb is now moving, and that will allow less pain and less discomfort in the residual limb. That's an example, and it works. It's effective in terms of treating pain.
And I had a full-blown attack on the Saturday night there. One of the ones that would have made me medicate myself and just curl up and just pray that it would go away. And about 20 minutes using the mirrors, it was completely gone.
But Dr. Burbrayer warns mirror therapy may not work for everyone. Patients need to be emotionally and mentally ready, willing to try, and persistent in using the mirrors.
It's going to be a lifelong process, but I think for now it's the results are fantastic. I'm not afraid of getting up in the morning and how much pain I'm going to deal with all day. I have a way to deal with it now that is working, and the more I work it, the more it'll work for me. And I'm not having a lot of phantom pain these days.
At Sunnybrook's St. John's Rehab, I'm Catherine Nasmick.
Pretty wild, right?
Yeah, the mirror stuff's a trip.
So that phenomenon is not completely absent from our own experiences with pain. It just feels different because there's no limb there. But the fact that you can have pain without any signal coming out of the limb shows you how pain can work. That it's very much rooted in our spinal cord and our brain. So, like this, there's kind of a renaissance going on in medicine right now, looking at cognitive neuroscience and psychedelics and pain and where they all come together. And the studies on psychedelics are incredibly interesting for a few reasons. And now there's a couple that are right on the verge of being FDA approved. Psilocybin is very close. MDMA is probably the first one that's going to be FDA approved because there's a bunch of VA studies showing how effective it is at managing PTSD. When somebody has PTSD and chronic pain, there are similarities here. So they're different diagnoses, but they affect people in a similar way, and they have a similarity in how we treat them. Now, MDMA is known to basically shut off the amygdala in the brain, like the fear center of the brain, and so you can process, if you want to talk about things that trigger you, you can do it while you're just smothered in this sensation of love and safety while you do it, and you can essentially rewire your association. And then substances like psilocybin are very good at kind of breaking rigid thinking. So if you've ever had an injury and you're just kind of caught in a loop of how you treat it, and it's when we become depressed about it, there's a very cyclical mental pattern that kind of anchors in. When you introduce psilocybin, it's essentially very disorganizing to thought patterns. And I mean, these things they're not accessible to people right now, but they will be in not that long, and I think they're quite powerful. And ketamine is already being used, and it's available in town right now, off-label use in clinics. You can have a nurse practitioner administer it to you for major depression, anxiety, and it can be used for chronic pain. And it's interesting why it works, is why I wanted to talk about it. There is a component of your brain referred to as the default mode network that is a few hubs of the brain where we essentially define our sense of self. So your goals, your drives, your motivation, who you decide you are, lives biologically in tissue in your brain. And that stuff can be very loud activity-wise. Like if you're a depressed person, we tend to think of it as like you're kind of locked in your own thoughts. You feel stuck in your own mind, and the joy of the outside world becomes kind of absent because you're so internally focused. These drugs essentially selectively shut off that region and allow you to then like experience the world with less of that ego driving the experience. And it's the nice thing about the studies on this is it doesn't have to be a repetitive thing. You can do it once and then you can remember it forever. And it doesn't have to be done like a daily treatment the way most antidepressants are done. And it's showing a lot of validity in treatment of depression, anxiety, and persistent pain, all for very similar reasons. And one of the components that's really intriguing in this is the idea of neuroplasticity. So neuroplasticity is the idea that your thoughts are action in parts of your brain, and we become trained into certain thoughts and trained into certain behaviors, but you can learn to think differently, and psychedelics essentially disorganize your old thoughts. And if you look at the picture on the right, the DMT and LSD, this one doesn't look at psilocybin, but it's looking at LSD. You're looking at a neuron, a single neuron. So the one on the left that's labeled VEH, that's an untreated neuron, right? It's just going wherever it goes. Now, when you introduce LSD, you get this effect where the neuron essentially starts branching and trying to reach connections around it. So your neurons are literally trying to reorganize themselves into different patterns. And it creates the opportunity for somebody to think differently and it's less of an uphill battle. You can sit here and you can try and think differently, but it's very difficult to engage. But when you do it in a clinical setting, you can introduce a drug like this, and it essentially primes the system to allow you to think differently shortly. So it's not a given that you can't take this, go to a concert, freak out, and have a great experience. You have to do it in a setting where the set and setting are set for success. So you feel safe, you have an intention, and you have a purpose of why you're being there. And you're going to try and reassociate a relationship in your body. Say you're struggling with back pain or knee pain that is just not going away, and there's no explanation for why it's there. You're going to relearn this association. There is a place for these substances in this kind of treatment. And I think in my lifetime and in my career, we will see that be a reality. It's actually not very far off right now. I don't think everybody out there needs to go use psychedelics. I'm not preaching like Timothy Leary was. I think it's powerful medicine, and it has the potential to help people. But just even the idea that it works can help people understand that it is possible to have a different relationship with your body, and it is possible to have change just through changing your mind, essentially. And that story for me is very hopeful. It gives me a lot of motivation in my career and motivation in how I work with people. It's not easy though. And I will say that every injury is different, every pain is different. Sometimes there are very, very mechanical problems that happy thoughts will do nothing for. But there's a real deficit of what we're talking about going on in medicine that we see momentum building on. And that's what we wanted to present today. So that was all I had.
I was going to add with the psychedelics, I think people also think of using these as like passive agents in their healing, but it's definitely something like, so I actually did 2 sessions of ketamine with a site in Bend, and I did 6-7 months of really intensive work with a physician out of Chicago of like trying to change the way I think and really kind of fighting with myself and trying to reshape the way I perceived things, and kind of had this like game plan going into these 2 sessions. And so they were really, they were very healing, and within like 3 days I was 90% pain free and like quadrupled my activity and felt pretty normal again. But it wasn't just this like, oh, I'm gonna go do ketamine at this like place in Bend. It was like, you know, I went, and then there's this pretty intensive integration, and then you're working with your therapist, or I worked with the woman I worked with in Chicago, and it was a pretty difficult couple of weeks. It was really emotionally, like, there was big release of emotion and things that I didn't even know were there. And so, yeah, it's not a passive agent. It's definitely like a tool to kind of access a part of your mind that you haven't been able to, and then you can use this increased neuroplasticity and kind of this like breakdown of the default mode network, which is what's kind of replaying that like story you're stuck in, and you can like rewrite the story moving forward, and kind of reshape things. And then because pain is biological and psychological and sociological, it has huge influences on pain, and PTSD and depression. It was an incredible tool, but definitely a tool, and I think in a therapeutic setting, it's really helpful. Yeah.
Strong medicine. Right. Any questions? I feel like we uncorked more room for questions than answers on anything, and that's kind of the purpose of this whole thing, is to not come up with an explanation for everybody's pain, but to open options on like, this stuff is extremely complicated, and you know, everybody I see in the clinic, it's now like, I need to know how they slept, how they had a fight with their spouse, like what their job is like, how much flow state they've got with exercise. Like, it's like Joelle's statement, it's always all things. And your pain fluctuations are always tied to everything now. So we always talked about these things like mind-body connection, as if the mind and the body were separate entities. There is no boundary between the two. And, you know, that's a hopeful story. Like, I think it's a story that paints a picture of options for improvement, right, in the system and in people's experience.
Do we know yet if any of the drugs like ketamine or psilocybin have side effects, negative side effects?
Yeah, so if you are somebody, there's a theory of, you can think of the brain as like in a high entropy state or low entropy state. So like you are very, if you're depressed, you're very like rhythmic thoughts. If you are schizophrenic, you're very disorganized thoughts. If you're somebody who has a tendency towards psychosis, like with schizophrenia in your family, that drug pushes you into that direction. So it's destabilizing to thought, and it's destabilizing to rigidity, but sometimes people are sitting on a really unstable foundation. So they're not toxic in terms of like, it doesn't cause cell death, but it can be, you know, somebody's sense of reality can be really rattled by it. So
it's not for everybody, and you have to
They definitely
tease it
vet
out.
you. Yeah.
Yeah, I mean, each one is different. I mean, there's different concerns for ketamine and psilocybin and DMT and LSD, but they all have, you know, it matters if you're on heart medications, and I think there's a lot of complexities there, how it interacts with other drugs. But I think
it's also important to know that you're only using psilocybin or ketamine like once in like a 6-month period, or maybe just once forever, and you're gonna have this like momentary high or fatigue post infusion of ketamine or post taking of psilocybin, so there's that's why you're in a therapeutic setting.
Yeah.
But what's nice is that it's just that one and done as opposed to taking Zoloft every day with that list of side effects.
And the experience itself, like, if you go in to see somebody who's going to guide you through this, like, for instance, with psilocybin, they would expect, okay, you're going to eat this substance, your serotonin levels are going to be up like this, you're going to feel really elated, a sense of love and oneness and whatnot. As the drug wears off, you're going to go below baseline for a while. Like, there's a rebound effect where you're going to feel lethargic and empty, and you'll probably just need to sleep then. So you have to embrace the fluctuation that's going to occur, like, as you take these substances. And they're all a little different as far as, like, how it cycles. So after ketamine, you'll feel very, very kind of scattered and, like, disorganized. Like, you can't lock your eyes onto one place. You're just sort of, like, bouncing around, which isn't it's an odd feeling, but it's not, like, inherently stressful. You can't drive when you're like that.
It kind of feels like it's used as an anesthetic as well, like for surgeries.
With children.
Yeah. So honestly, if you've had an orthopedic surgery or any kind of anesthesia administration, you wake up and they're there driving you home, and you're kind of just like, like it's fairly similar. Yeah.
There's just more of a neuroplasticity
Yeah.
overlay to this than other anesthetics. So, like with ketamine, there's a really increased of brain-derived neurotropic factor that, like, primes your brain for, I think, months essentially, where you're it's easier to redirect thought into new patterns, which is not the case necessarily with other anesthetics. So, any other thoughts? Yeah.
So it seems like there's more and more diagnoses that are attributed, like fibromyalgia, even Lyme disease, rheumatoid arthritis, that chronic pain is part of. Does this apply to those types of?
Yeah, there's always going to be a biological component to those, but you're going to get a really messy interplay between. Fibromyalgia is a tricky one because
that's
it's
the one
very.
I think of that seems real.
That one's so
Fuzzy.
It's not particularly well defined at this point, and it doesn't seem to exist equally in different parts of the world. So there's a huge cultural overlay.
Right.
But you can still treat it on a similar level. Like if I work with somebody who has fibromyalgia and we're working towards, like, we would still work to change how they interact with the pain. Like, there's this feeling when you have those pains of, like, there's something wrong in there. Like, you can validate that. Like, it does feel that way, but we need to, like, not let that stop you from doing the self-care that will make you feel better eventually. So there's kind of a redirection that goes on when you work with those people. I don't know how, like, ketamine would play into that. I've never seen anything where ketamine has been used with fibromyalgia, but I mean, it's known to have very, very strong antidepressant effects, and one of the best treatments for fibromyalgia is antidepressants. So it's probably going to be as useful or more useful than the current treatments, because we're not particularly good at managing fibromyalgia. It's complicated. Yeah.
And I think with, like, autoimmune disorders, there's a very strong correlation with nervous system regulation. So people often go into, like, a flare when there's stress in their life. And so a lot of these mindfulness kind of grounding techniques, you can limit your, like, flares because you're not dysregulating your system. You can kind of have, like, a bit more of, like, a hand in that process. And then consequently, you're not getting inflammation or pain. And there's been some, I've read some studies on, especially with, like, lupus, people going into remission using a lot of these sorts of practices. But there's definitely, like, there is a biological influence with, like, RA, for example. But you can use these tools to kind of mediate that process, and people do really well with it.
We know that the immune system reacts to the stress state in your body. So if you're consciously, and you can get in a looping situation there where your fear of your disease is provoking a sympathetic response in your body, which is perpetuating your disease. So it might not be, like, a very direct thing of, like, this is causing your disease, but it's definitely making it worse. Right. So a lot of those diseases, there's no one answer. It's more like you take 5 factors in the person's life, change them all, and you slowly redirect the disease state away. it's been my experience with autoimmune issues. So, any other ideas? Yeah?
I just had a question. Like, what would you, the psychedelics aside, what would you call this sort of therapy?
It's definitely a brand of cognitive behavioral therapy with a physical focus.
I've
So-
heard it coined pain reprocessing therapy. It's
Mhm.
kind of a new buzzword out of like Los Angeles. There's an institute in
Yeah.
LA that does pain reprocessing therapy, and they're training like psychotherapists, LCSWs, psychiatrists, psychologists across the country in this, and then trying to get it into like clinicians' offices as well.
And this modeling was, when I graduated from physical therapy school, like we didn't dig into this at all, but now I know that physical therapy schools paint this picture of pain from the get-go, but it's a very difficult thing for a young student to understand. Like, unless you've went through a crisis in your life where you've got caught in a loop and you felt the despair of like, oh, I was thinking wrong and I had to break out of that somehow, it's difficult to work with patients and see that in them. So it takes a layer of empathy to be able to work with people that are struggling in this way. If you're a physical therapist and you've really never struggled and your athletic prowess was always just try harder to get to the next level, that's the strategy you're going to push your patients to, and that may really frustrate some of them. And I've had points in my career where that was what worked for me, and it does work for a subset of patients, but it really doesn't work for some of them. And it's really frustrating when you go see a medical practitioner and they allude to you basically not trying hard enough, or that you need to work harder, and you're already like, I'm all in, and it essentially just makes hopelessness. There's a learned helplessness that evolves out of that. It's just engineers depression. So
do you foresee, oh, sorry,
No, go
just a
ahead.
follow-up question. So
Yeah.
do you foresee this being more of just sort of a side modality that some social workers, physical therapists, medical doctors, orthopedists kind of integrate into their
I think it's
their
becoming
work,
more the
or
norm.
do you
Yeah.
think it would be a certification of its own that somebody would have? It's kind of,
Well, like everything in medicine, it's like a slow evolution. Old ideas have to die a little bit, and like the dinosaur models of pain are dying off, and like this new model is wedging its way in. It's not, I wouldn't say that it's like a tangent from the norm at this point. It is becoming more of the standard to understand it in these terms. But it's hard to if you Google, you're looking for a therapist that's going to work on this, it's not easy to encapsulate, how do I find a practitioner? It's all just word of mouth, or, what does Michelle Grimm label herself as?
I think she's like a pain clinician. She works with someone who studied pain at like Johns Hopkins, and then they started like a clinic that's attached to it's kind of like I don't even really remember how I found her. I think the Johns Hopkins connection, but I think she just calls herself like a pain clinician.
Yeah.
And it's not like there's no insurance coverage, it's still out there enough that it's not covered by insurance, so it's all out of pocket. But she saw a need. She's an orthopedic surgeon, and 70% of her patients she'll refer to this center, and half the time they don't end up needing surgery, even though they have, degenerative whatever. And so she saw a big need for this. She also runs like a yoga institute for chronic pain, which is pretty cool. She does it all. But I think she just calls herself a pain clinician. I think there's a lot of different language still.
I just call myself just a pain specialist or whatever.
Yeah.
It's pretty generic. But the whole orthopedic world is going through a period right now where all the surgeries are kind of getting evaluated against placebo sham surgeries, because that was never a thing in the past.
Question. Talk to me about sham surgeries.
Because the philosophy 20 years ago was we're not going to put people through a sham surgery because that would be an affront to them somehow, but instead we're going to allow surgeries to get done rampantly without any real validation of does it actually work.
Yeah.
So now a lot of and there are a few surgeries that have been shown they are not better than, there's quite a few of them that were very standard 15 years ago that have been
Insurance
shown.
covers the ones that don't work, but not the ones that work.
Yeah.
Mhm.
It's all packaged.
What are the ones
Yeah.
that don't work, that have been
I mean,
discovered?
degenerative arthritis in the knee, debridement, lateral release of the knee is a debated one. I believe there was one on like decompression of the subacromial joint in the shoulder being kind of like iffy on that.
Even like meniscectomies.
Yeah, like
Small ones.
you have to think of a surgery as being like the ultimate placebo. It's you're putting through somebody through like, okay, you're going to go see this guru who's going to do the most invasive thing you can think of, and you're going to have this whole hoopla around it, and then you have to go through a rehab afterwards. Like, if the surgery did nothing, you've engineered a massive placebo, which is real. So it's hard to tease out like what's what there, you know.
Yeah, the sham studies are interesting. They do, essentially you go in, you go under, you wake up, it looks like you've had surgery, but they haven't actually like performed anything. You would go through an entire recovery process and then like
They'll cut a hole in you, like
yeah,
they'll wash there.
yeah, right. They'll like stick the, create
Well, so
ports, but they're
they-
not doing the repair.
They take it to the level of even spending the same amount of time
Yeah.
in the knee. So they'll cut holes in there, inject the ports, flush the knee out with saline, and then sit there.
Yeah.
We have to wait 30 minutes,
Yeah,
remove tools, sew up, done. So,
it's the full impression that you've had a surgery.
Yeah.
yeah.
There's even studies where, like, if they tell you you didn't have much, they didn't need to do that much. People, like, recover better than if they were told, oh, we had to fix this, this, and this. And then they've seen the opposite, where some people, when they've heard, like, we fixed everything and you had so much, but we fixed it all and you're good to go, they do really well than people who heard, oh, there isn't that much wrong and it didn't match, like, their pain. They don't do as well.
Like the language is a tipping point there.
Yeah.
Like, it was a real trouble in there, or, oh, we did a great job in there. Like,
Yeah.
The story could be, it took a long time, or holy cow, we were in there for a long time and could barely put it together. It's like, you can go both ways of that story, and it sets people in motion in different directions. So, complicated conversation. So, maybe you can apply it to your own problems. Maybe not. Anyway, anything else?